Thank you very much to the Vatikoti Foundation, Professor Bhandari and Raj for the invitation. So this is predominantly a step-by-step approach towards doing a robotic partial nephrectomy. I'm assuming that most of you are familiar with most of the steps of partial nephrectomy, so there's no rocket science here. We'll go through step by step, but at the same time, the whole point of the discussion will be to involve our esteemed panel and see what they would do anything different from what I'm seeing here. Again, the one thing to remember is there are different ways to skin the cat. So there's no one perfect way. In different hands, different people have different preferences, and I think that's something that everyone should be cognizant of. So again, I would like to invite all of you to come for the pre-AUA meeting that we are hosting in Miami Beach on urologic oncology and robotic surgery. There will be 3 live robotic surgeries and a lot of experts in urologic oncology. So let's go to planning and approach. These are the steps that I'll cover during this session. So we have the pre-procedural planning, which is extremely important. As you can imagine, imaging is the cornerstone of management of renal cell cancer or renal tumor. So there is no substitute for mediocre, there's no excuse for any mediocre imaging. You have to be as well prepared as you possibly can before you embark on any partial nephrectomy. And then we'll go towards several operative steps in terms of positioning of the patient, port placements, the general approach about the right side, left side, the instruments that are commonly used in the robotic setup, the ischemia controversies, if you will, and the suturing techniques, the tumor excision and the suturing techniques, and some of the more recent tools that have been recently used, like the robotic tile pro technique, the fluorescence imaging, and the value of these. So as we go here in the pre-procedural planning, our preferred method is a CT scan, a 3-phase renal CT scan, usually within 3 months of the surgery, because renal cell cancer can grow. Just is to both assess the size and location of tumor, assess the vessels and the vascular anatomy, both the arterial and venous, and the surrounding structures. And I will tell you one thing. So if you point here, you look, this feels like a lower pole tumor. If you look at just one coronal section, most of us would agree that this is a lower pole tumor. But this is where oftentimes you can be fooled by just 1 or 2 images if you have them. It's always good to have a 3D imaging, and so many times what seems like a lower pole tumor or a middle portion of the kidney tumor actually is a middle portion or an upper portion of the kidney tumor on sagittal imaging. So it's very, very important to know, because if you're not prepared, you may expose to lower pole trying to find the tumor. You're not seeing the tumor and you're thinking, what the hell is going on? When actually it's just slightly higher up. It's just that you've not looked at all the images properly. Very important to know. This is the bed positioning for the SI. Now again, we actually were the first academic center in the world to purchase the Da Vinci XI. We did a live surgery at the AUA last year doing a robotic partial nephrectomy with the XI. And since the purchase of the XI, we have 2 XIs now. I have not done almost 95+% of my kidney surgeries are with the XI. And only less than 5% when I'm running 2 rooms and I have a nephrectomy, I'll do it on an SI. And I'll tell you one thing, no matter what the company says, I find the vision of SI is much better compared to that of XI. I think Intuitive recognizes that, realizes that. We have worked with the company over the past almost a year now in their animal labs. We've gone through several iterations of the scope of the XI. There's an orange hue to everything. But that has subsequently changed. They've recalled those scopes. Now we have a lot of new scopes that are significantly better, but they're still not the same. When I go back, actually in the 2nd week of February, they're coming out with the absolute latest version that is expected to bring significant improvements. Remember, XI is a very new system. It's a revolutionary system. That being said, you only find out about some of the flaws of the system when you start using it. But the company is working very, very hard. One of the other major problems, and I'll come to it when you do the port placement, is about the mode of entry of the trocar. So I'll cover both the SI and the XI, fully recognizing that most centers in India have SI, and even most centers in the United States today have the SI system. It's fascinating. I got several, because I'm in Miami, I get several phone calls from my counterparts in Brazil that for some reason there is no approval to to sell the XI system in Brazil, and yet they are selling the XI system very easily here in India. So I don't know the reason, but it's just interesting.
Dipen, can I ask one question?
Yes.
Can we have SHD also, one down below?
Look, it's basically you can, but should you?
No, I'm just asking. Some people have SHD. Some people have SHD, and obviously the cost of the SHD is definitely lesser. So that has been one of the things which have been also pre-owned machines, SHD, and of course prostate there's no problem. But as far as the upper abdomen is concerned, what about SHD? Would you be?
I think SHD and SI, in terms of the port placement and in terms of everything else, is pretty much similar. But if you want to do multi-quadrant surgeries, nephrouretrectomies, partial nephrectomies, especially the challenging locations like upper pole tumors, posterior large tumors, XI is so much easier. It's just a piece of cake. If you want to, with the SI system, sometimes it's a stretch going all the way to the upper portion of the kidney. With the XI, it is so seamless that you can actually sometimes start your surgery going through the liver and the hepatorenal ligaments, taking that out, completely freeing up the lateral portion of the cava, the adrenal, and start from there. It is so easy to go with the XI. And I'll show you the port placement. It's very, very easy. My answer is, honestly, if you can, go for the XI rather than go behind.
Do you also feel that the camera gets more easily fogged? Because I have had the opportunity of using the XI, and I found that while doing a prostatectomy, the camera was more easily getting fogged as compared to the...
You know why that is? That's the Bowie. That's not the camera. The Bowie is very different. They have their own Bowie. So the SI, you use you're using the Valley Lab or any other Bowie system. With the XI, it's their own Bowie. They have their own Bowie from Intuitive that comes ready-made with that. And the Bowie is very different, so there's a lot of smoke. The advantage is every single case that I do, I have the air seal. So because of the air seal, the assistant is constantly sucking while still maintaining the pneumoperitoneum, and it's not a problem. Is everyone here familiar with the air seal technology?
Yes, I am. I think it's indeed very, very good because the pressure stays the same. That's number one. You have the smoke evacuation, that's better. And because the pressure stays the same, you don't risk that the assistant is sucking out all the air so that the abdomen falls down and that you lose your trocar. So, that's quite important.
Yeah, so that's why...
But another problem I've noticed with the air seal here is that just in case there is a little bit of bleeding and the fluid gets sucked into between the two layers of the lumen of the air seal trocar, then it packs up. Then it doesn't work.
We have not seen that often. The only downside to the air seal we have seen is the increased incidence of subcutaneous emphysema in the post-op period. I mean, there's nothing major about it. It's just an annoyance to the patient, but that's the only incidence that we have seen higher. But otherwise, the only advantage is it cuts down your operative time significantly, your blood loss significantly. It's just much more efficient.
Yeah, but we encountered this once, and indeed you must beware that there is no blood coming into this trocar. So that is the only disadvantage, if I may say so. But it happened once as well to us.
So the other thing you can do, Gagan, to overcome the Bowie issue is that you can de-zoom. When you are doing with your XI especially, and you're too close and it clogs up, just de-zoom. That way you can actually go a little bit behind, have more of a perspective, and away from the smoke. But the Bowie is an issue as well.
Thank you.
It's a good point. So anyway, it's a bed positioning for the SI. What we used to do was, this is the standard bed, this is the foot end, and this is the head end. But in the SI system for kidney cases, we have to reverse the bed position. And this is the head end, and this is the foot end. And that's because it allows the patient card to straddle the corner of the base of the bed, and it facilitates the docking over the shoulder. So because imagine if you were to do a partial nephrectomy on the flank, the robot is not coming straight, it's coming at an angle here. Now, that being said, there are few groups that go directly perpendicular to do robotic partial nephrectomies. We prefer to go from the shoulder at an oblique angle. And I'll show that in a second. This is what it is. So this is the base of the bed, and this is where the robot is coming from and attaching itself. This is the patient positioning, the way we do it. It's pretty routine. This is the patient on the edge of the bed. It's very, very important that the patient is on the edge of the bed so that you don't have any mechanical leveraging of the instruments, while especially your assistant while manipulating and helping you. The bed is flexed. You have the axillary roll. You have two straps to secure the patient. And again, this is the room positioning. You can see the surgeon at the console. You can see the patient here. This is the left side up. This is the robot coming at an angle. This is the assistant. This is the scrub tech. And these are the monitors. So this is...
Dipen, just a point that what we do in our kidney positioning is that we keep instead of the arm going over.
You can do it like this, absolutely.
We keep it straight.
Yes.
And that helps.
Absolutely, that helps. So Dr. Alawat raises a very good point. In fact, there was a poster, very nice poster at the AUA a couple of years back on the same technology where you don't put the arm like this, you just tuck it in, and that helps you maneuver the robot without hitting the arm. You can do that as well. Again, a lot of these technical difficulties of maneuvering is significantly more with the SI. You will see with the XI, a lot of these problems are completely eliminated. It comes from the top and it's in a straight line. So, and again, coming back now, this is critical. So, how you position the camera is, how you position the ports for an SI is absolutely critical. Remember, unlike the prostate, which is a wide pelvic cavity, you have a lot more room in the prostate and bladder. In the kidney, it's a very narrow cavity. So you may not have, you don't have that much of a room. So this is the port placement, for example, for a left-sided robotic partial nephrectomy. As you can see here, this is the camera port. It's lateral to the umbilicus. For the obese patients with high BMI, this port can go even more further lateral. It should go further lateral. These are the robotic ports, one here on the right side, one here on the left side. And the fourth arm is actually coming at an angle like this, which is about 2 finger breadths away from the anterior superior iliac spine. And the fourth arm is critical. I've done close to 300 plus robotic partial nephrectomies, and the first 50 or 100, I would say, I did it just with 2 arms and had an extra assistant port. But since I've started using the fourth arm, it's like you having your own assistant. It helps you immensely in traction, in retraction, in handling the kidney, in manipulating the angles when you're suturing or doing tumor excision, so on and so forth. And this is where this can be a little bit of a hit and a miss in an SI system, because sometimes there is not enough space. And think about the angles here. Your camera is looking straight. The 2 robotic arms are looking like this, but the fourth arm is actually going in a completely different direction. So there is a chance of clashing. There is a chance of things not quite working out. What I will tell you is not to get frustrated. So when you are doing the surgery and you're not able to use your fourth arm right from the word go, that's okay. Just make progress, just do the bowel mobilization, lift up the kidney, and then you'll find a little bit of room to then insert that fourth arm and lift that kidney up at a traction, so that then you can go for the hilum. So don't just give up immediately if it doesn't work from the get-go.
Another point, if the fourth arm is and third arm, there is a clash, then you can just turn the table slightly to the opposite side, and sometimes that works.
Absolutely. The only problem with that is that in the way it is set up is that if the system is docked, you can't move the table. That's a problem.
It's while docking.
Yes.
One more thing is that the arms many times hit the leg. Mm-hmm. So to prevent this, sometimes we use an extra longer and...
I'm coming to that.
Okay.
So Arvind raises a fantastic point. So almost exclusively, even if you give me the thinnest of thin patients, I always use bariatric trocars for kidney surgery with the SI system. So this is the traditional trocars. Remember what I told you, it's a very narrow space. So your robot arms are coming at an angle and then hooking up to these trocars. So there's a lot of chances of clashing. But if you do this, if you have a bariatric trocar with a significant more length outside of the body, then your arms are more spread apart outside and it avoids the clashing. So every single kidney case that I perform with the SI, I always use bariatric trocar. But that's a great point. We don't have to do that in the XI, unless the patient really needs bariatric because of the body habitus. But that's a great point.
Can you just exactly tell us the location of the fourth arm port? Is it like medial to the anterior superior iliac spine, or is it superior to the anterior superior iliac spine?
No, it's medial. It's medial to the anterior superior
At the
iliac
same
spine.
level as the anterior superior iliac spine.
At the same level, yes.
Okay.
Yes.
So-
But again, Gagan, remember, the last trocar that we put, or the last port that we put, is that port. So we first put all the other ports, see how the alignment is. We put the camera, see where the kidney is, you know where the tumor is, and then you put that fourth arm. So if you have to manipulate a little bit up or down, you should have the ability to do that. There's nothing is set in stone. Whatever works for you on that day is the best.
The occasional problem that we've had is that the elbow of the robot, of the fourth arm, hits the bolster along which the patient is supported and behind the back. So these bariatric trocars will probably help in that. Or
It definitely helps. I mean, look, there's no question. There's not a single case that I do with the SI where I don't use a bariatric port, so that helps. And despite everything that you try, sometimes it's still not perfect, but you should just continue with the surgery and see, you can then use it after a little bit of more dissection. If you still can't, then even at the time of surgery, there's no harm in undocking and putting it at a place where the rest of the robot is docked, and then putting it at a place where it will work for you. And I've done that occasionally as well.
Yeah. I do just a little bit different. I start with placing the fourth arm. So I go as lateral as possible. I look where the lower pole of the kidney is, and 2 centimeters caudal to it, as lateral as possible, I place my fourth arm, so that I have as much place as possible to place the medial trocar down as far away as possible from the fourth arm, let's say. And another thing is that I place the elbow of the robotic arm almost under the camera arm. You understand? So that you have much more working space with it.
I didn't get that.
Yeah, well, you can come with the robotic arm like this, but I cannot do it. But if you place this elbow down, you have much more working space with your instruments.
So the other thing also, Gautam, what you can do, Gagan, what you can do is, once you put everything, and there's still a lot of clashing, you can try outside before even starting the case, maneuvering the way Alex just mentioned, in different ways in rotating the elbow. Both the elbow of the fourth arm as well as the other arms, to see that they don't clash outside. If they don't clash outside, the chances of them not clashing inside become significantly higher as well. But it is a trial and error mechanism. The one other thing I would mention about port placement is different people have different techniques. So I typically use a 30 down for all my kidney cases. So I use the camera medially, but there are groups that use a 30 up camera, and they actually have the camera arm significantly more lateral. So this camera arm that is here will be somewhere here. And the rationale is, if you do that, then there's less crowding here to put your robotic arms in the assistant port. I've tried that a couple of times, but for me, the vision of the hilum and the kidney was very unnatural, and so I reverted back to the traditional way.
So what about 0 degree if you have to use a hilum?
You can use a 0 degree for hilum. I've typically found 30 to be pretty good for all my steps in a partial nephrectomy.
Again, with the 30, the clashing of the arms is much lesser, because your robotic that port, and there is a place for the assistant to work. With a 0 degree, with all arms crowding around, there is no place for the assistant to work.
The other thing I also want to tell everyone is, remember, this is again kidney. This is not a prostate or bladder. And sometimes, despite everything that you have done, despite all your best efforts, it's not ideal. But that doesn't mean you just quit and give up. You just grind your way through, and it's just a little bit more difficult than your average simple case, but you can still do it.
Yeah. I agree, but I hated to change cameras, because then it's foggy, you have to warm it up again, it takes time. So for me, you lose a lot of time with changes. Yes. So if you can avoid this, also in prostate, and so prostate, I do everything with 0 degree. Kidney, I do basically always with 30 degree lens down.
That's exactly
so it's about just to try to avoid unnecessary maneuvering on the bed. But okay, that is my opinion.
Yeah. No, but Alex is absolutely right. It's just like the more you do of something, the more you are comfortable with, when you're starting off, for example, at the prostate, there's a big median lobe. At the bladder neck, a lot of people will use a 30 down to get a better angle and everything. But once you get experience, you pretty much, train to do everything in one go, and then it's a matter of efficiency more than anything else. Yep. But that doesn't mean you cannot switch. If you're in a tough spot, by all means, you should try everything you have at your disposal to make it easy for you.
I've got a question. Do you really need a fourth arm for the kidneys? Can you?
You don't need a fourth arm, but if you don't have a fourth arm, you definitely need one extra assistant port.
Exactly.
the thing is, if I have to, given a choice between relying on myself as an assistant versus relying on an assistant, I would definitely rely on myself, because
No, no, thank
I
you.
can manipulate the traction, the force that I'm using, all those things much better than my assistant can. So for me, the fourth arm it works very, very well. I don't know about the panel, what they
I
think.
fully agree with Dipen. I started in my initial experience was with 3 arms instead of 4. And now, if I would only have 3 arms, I feel amputated. So I am so used to the 4th arm that it's difficult for me to do a case without, because it has become so routine to have your 4th arm, to push away the kidney, to lift it up, to see well. So that is absolutely, for me, mandatory to have one if possible.
And remember, especially for very obese patients, even after having all the 3 robot arms, the assistant port, sometimes the bowel is a pain in the neck, especially on the left side. And sometimes there's a very large medial tumors, if you're doing a nephrectomy, you still need to have one more assistant port just to retract the bowel. Occasionally you have to do that as well. So the more I rely on myself, the better it is.
We always put in the fourth arm, but the fourth arm is used at the step when we reflect up the ureterogonadal packet and while we suture the renal parenchyma. Otherwise, we don't use it. Always we put in the fourth arm.
Yeah, but if you have the arm, you can use it anytime you need to help yourself. So for me, even to, let's say in a very big patient, even to identify the retroperitoneal structures, you just put it, lift up the Gerota's fascia, and your assistant is retracting the bowel. You have this nice plane where you can just dissect the ureter and the gonadal. So, you can, if you use it, you can use it any way you want to use it. So.
Dr. Dipen, is there any benefit in flexing the table or giving slight head end up or head end down?
Yeah, I mean, we do routinely flex the table because it opens up the space between the costal margin and the ASIS. So we open the space to make it more favorable. But we typically don't feel any need to a Trendelenburg or something like that.
And what about keeping a roll beneath for the kidney bridge, as a kidney bridge?
I mean, you can or you cannot. I don't think that it's one way or the other. It's personal preference, I think.
I think there are pros and cons given for that. If you stretch it too much, then the abdominal distension is less, and the distance between this abdomen and the organ is less. So you have less space there. So but if you leave it lax, then the distension is more, and the working space is more. So
if you look at this slide now, see how easy it is. Now, I mean, it's just so easy. Everything is in one straight line. You look here, you have the camera, you have the assistant port here, this is the umbilicus, this is the camera port, this is the first robot, second robot, third robot. So remember how this robot arm was coming like this from here? Gagan, do you see that now? Now you don't have to think about all this hitting and clashing and all those things. This is right here in a straight line. So it just makes it so easier. Also remember, the inherent length of the trocars for the XI is longer by a couple of inches compared to the SI. So that also helps for kidney surgery. So you can reach any portion of the kidney you want to reach, you can reach. I was having a discussion yesterday about someone in Henry Ford doing retroperitoneal surgery for kidneys. And one of the reasons was the reach and so on and so forth. And honestly, if for any posterior tumors you give me, medial, lateral, superior pole, I can flip the kidney. It takes me 5 minutes to degerotalize the kidney, flip the kidney, and do it any angle the tumor is. You can do a good robotic partial nephrectomy. Yuvraj.
Dipen, initial cases I used to use all the 4 ports, whatever the 3 robotic ports, the normal length. But I started using one extra length for the assistant, the 4th port. But now I started using all 3 the obesity trocars. The clash outside is much less. But still the only problem I had was that the right arm, the dominant arm, the instrument was not going to the upper pole on the left side.
Correct.
So then again I changed that only one port to a regular length. So if you use 2 extra length and 1 regular length, the clash outside is much lesser. That's what I felt.
Okay.
So now I'm using regularly.
Yeah, I have not done that, Yuvraj. I typically use all bariatric ports for the SI for kidney surgery. But that's a good point. I have not used that. But now, like I said, every kidney case, I do it with the XI. So all those points are kind of irrelevant, at least in my practice.
One of the problems of XI is the size of the camera, which is, SI is 12 and this is no, does that make any difference?
Well, I don't think that the size of the camera makes a difference, but it's a different chip altogether. So the vision is different. But even that, I would ask the company to give us, the surgeons, the option of using the 12 camera. So for example, here's the problem. So if I show you this, the previous slide, so see this? So typically, when you put a first port in, I always use the Hassan technique because I always want have the safest access. I never use the Veris needle, and this is a problem because all the trocars are 8 millimeters. All the trocars are 8. So the problem is you can't do a Hassan with an 8 millimeter technique. So you have to make a slight bigger incision, put this port in, then you have to take a stitch to the fascia to secure the camera, so on and so forth. And you know, the problem is whether it's a prostate or a kidney, ultimately when you remove the specimen, you have to extend that incision anyways. So I told the company, look, why don't you give the choice to us? For those of us who want to use the 8 millimeter camera, where that extra couple of inches makes a difference, let us use that. But for those of us who want to keep a better vision and use the 12 with the Hassan, give us the option of doing that. So I think they're seriously considering doing that.
Yeah.
So here's again the on the right side. I just showed one on the left side. Again, the right side. These are the 1, 2, 3, 4 straight line for all the 4 the robot ports. This is the assistant port, and this is the liver retractor on the right side. And you can see here, you know, there is minimal collision, minimal. This is in one of my own patients in my own OR. So here I'm going to show a left-sided partial nephrectomy that actually covers all the steps. This is the tumor on the left side, pretty large tumor wrapping the ureter. Again, this is the left colon. I'm mobilizing the colon right now. There's always this little adhesion at the splenic flexure, near the splenic flexure, between the omentum and the abdominal wall.
This is with XI.
This is the XI, yes, yes. So again, you can see the piece of bowel right here. This is the plane between the kidney and the colon. I cannot overemphasize the importance of being in this plane. A lot of people think that this is the easy part of the surgery. For me, it's all about setting this part of the surgery up. If you are in the right plane, and again, I'm going to just stop here for a second. So this is the colon, this is the kidney, this is the lobular fat here, this is the membranous fat here. It's critical. If you're in the right plane, things go beautifully. If you're in the wrong plane, especially if you're in the mesenteric plane, in fat people, generally you always have bleeders, you keep on tackling that, it slows down the case, you get frustrated, so on and so forth. So this is a very, very important part, I think, in going in the right plane here, because this really sets your case up. So again, this is the upper pole of the kidney. See how easily I can go the upper pole of the kidney with the XI system. Again, just mobilizing the fat. See all this fat? This is all the mesenteric fat, globular fat. Again, going down all the way. So you have to mobilize the left colon all the way down to the pelvic wall, to the pelvic inlet, as far as you can possibly go. So again, I'm going down. This is inferior. Again, this is the plane, like I said. This is the globular fat, and this is the membranous gerotas fascia. This is the retroperitoneal structure right here. And imagine now my fourth arm will come in and basically at the same angle. This is the left side. I'm using a fenestrated bipolar instrument. This is the monopolar scissors on the right side. And this is the dissection near the splenic flexure. See how easily you can go all the way up. And I always found that if you can completely mobilize the spleen and lateralize the spleen, or medialize the spleen, if you will, it really helps in the bowel not falling in your way when you're doing the kidney dissection. So this is the kidney. You can see the kidney here. And this is the retroperitoneum. We want to go in this plane. So see how I'm just going to dissect this. So this is critical. See the traction, counter traction. I'm going to go in this plane. You can see the ureter right here. Within 2 minutes, you see the ureter. And this is the fourth arm. So I'm going to stop for a second. See this? So how this is my third arm. This is my fourth arm. See how easily my fourth arm comes at the same angle and then lifts up the retroperitoneum, lifts up the kidney and the gerotas fascia and applies good traction.
The problem here is, fourth arm goes out of vision.
No, but not with the XI. So with the XI, they're all. So basically, think in this way. So if you have the two arms, your fourth arm is exactly on the same axis, just lateral. And the other feature of XI is, if you are trying to manipulate an instrument which is not under your field of vision, then it will tell you. It will prompt you, and it will tell you in the screen that the instrument that you're trying to manipulate is not in the field of vision. So that it won't even allow you to do that blindly. So you have to see the instrument and then you can manipulate. But that's a very good point. So here I am again, it's all about traction, counter-traction. See how this whole thing is being lifted up? And it sets up beautifully the dissection of the ureter and the hilum and the gonadal. Initially, that's the other point I wanted to make. Initially, I used to be obsessed with finding the ureter first. But after you do a lot of this, you no longer have to be obsessed about the ureter. As long as you find some identifiable structure, whether it is the vena cava on the right side, the gonadal on the left side, the ureter will come. Sometimes it's actually not, it's even good not to fish for the ureter. If you're in the right plane, it'll show itself. So again, see how, that's the other thing I want to point out. See how I keep on repositioning that fourth arm? So initially my fourth arm was somewhere more inferiorly. As I'm dissecting the gonadal and marching upwards to the hilum, I'm repositioning my fourth arm upper and upper and upper. And as I dissect this particular tissue here, my fourth arm ultimately will be somewhere here. So it will keep on marching upwards. And in females, you can have pretty substantial gonadal veins. Very turgid, you can have multiple gonadal veins, collaterals. So again, see how I'm advancing the fourth arm again? And now I'm going to take the gonadal vein. You can take it in several forms. You can use a ligature or a harmonic scalpel. You can just use a bipolar. Typically we just take clips and just take it out. Now this is the hilar dissection on the left side. You can see the left renal vein right here. I'm just keratinizing the left renal vein. So let me stop here and ask the panelists a couple of questions. So when you do your hilar dissection, do you believe in skeletonizing the artery vein for a good length, or do you believe in just dissecting enough to put a clamp on?
The first thing is that we never ligate the gonadal. We go medial to the gonadal and lift the gonadal and the ureter together. So that, because renal vein length is enough medial to that, and the gonadal gets lifted up really laterally. It doesn't even come in the field. And secondly, it depends on the necessity that, if you want to go for, secondary level artery branches or something, then it's necessary to skeletonize it. But if you want to just be on the main trunk, then it's not very essential. But one has to make sure that enough dissection has to be done to make sure that there is no second artery which is left, because that's often most of the problems that occur are due to missing a second vessel.
Absolutely.
During the dissection.
Well, for me, it's quite mandatory and standard also to isolate the main artery and to put a vessel loop around it. So if there is an acute bleeding or whatever, you can always pull, find it back even when it's bleeding. So for us, it's standard therapy. So the residents, when they do it, they have to isolate it. Mm-hmm. It's not always that easy, I know, but I basically want to do it.
We will always lift up the ureterogonadal packet in toto, be on the aorta, dissect the vessel from the ostium. Particularly, we'll take care of the lumbar veins and secure the lumbar veins. And as Dr. Alex said, that we'll always sling the vessels in case of an emergency.
So as you saw, there are different views in how to do the same thing. So I'll show what I do. See, on the left side, I do go right at the aorta because I want to, sometimes there's an early branching of the renal artery, and I want to go to the main branch rather than go to multiple 4 or 5 branches. Also, I completely don't believe in the concept of zero ischemia or superselective clamping, and I'll show you why. And so I believe in dissecting the artery and the vein enough to put a clamp. Here I am now opening the Gerota's fascia to expose the tumor. Again, very important, it's much more easier in a female patient to lift up the Gerota's fascia. In male patients, especially old patients and fat patients, this can be the most painful part of the procedure in just defatting the Gerota's fascia. And no matter what you do, it looks ugly. There are a lot of capsular small bleeders that can annoy you. So the point I was trying to make was that oftentimes when you're doing male patients and there's a very sticky fat to the kidney and you're mobilizing the fat, there will be a lot of capsular bleeding. It's very annoying, but there's nothing you can do about it. So rather than spending a lot of time in trying to control each and every blood vessel out there, which is not going to get controlled, you want to keep your focus on the main tumor. And those small little bleeders will be ultimately inconsequential. So again, we saw so I'm putting the clamp here. You see it's a pretty robust artery, you can see. Here I'm marking the tumor site. It's a fairly large tumor, as you can see, inferior pole next to the ureter. And when we cut the tumor, you'll realize how close the defect is with the main renal vein. So here I'm cutting cold. You can see the renal parenchyma here, normal. You can see normal renal parenchyma here. We're lifting up the tumor right here. And this is the edge of the kidney, the medial edge of the kidney. So one of the key things you want to realize is when you are cutting a tumor, you don't want to cut into one place and go all the way down and operate in a hole. You want to go into the right plane, but go more circumferential in toto. That way, you're not going to, your vision is much better. You have a more panoramic view of the entire tumor in the normal renal parenchyma, and it facilitates the lifting up of the tumor in a much better way. The other thing is you see here, my left arm here is just gently applying traction to the tumor. And my right arm is cutting, and the suction of the assistant is critical in doing it. Now, there is a suction port also available. There is an automatic, the robotic suction port, which is also available. The only problem with that is I've not used it since I've got the air seal, but when I did not have the air seal, if you use it more, your pneumo actually goes down. It's a problem.
So we have an experienced audience here, so let's go for some tips and tricks. Basically, a little difference perhaps is that before I start the resection, I already circumferentially coagulate the capsula, plus I go already coagulating 2-3 millimeters deep. So once I clamp, I can immediately use the blunt dissection. I hardly cut anything through the parenchyma. So I basically do this, and this is going extremely easily because you get that second enuclear resection plane, which I call, and only once I get into the in the hilum, then you have to cut. Yeah. Secondly, I more and more often do the dual surgery technique. So we have a dual console. So I have the second surgeon using the fourth arm with the suction irrigator. So basically, he can more easily assist you with the fourth arm just to keep your suction irrigator at exactly the spot you want.
So that's a good point, Alex raised. So typically, Alex, you're right, I mark the tumor before I clamp. In this particular patient, he had a significant cystic component. I didn't want to puncture the cyst or anything like that, and so that's why I did better. That's a very good point. Yeah.
While scoring the tumor, at our place we will always do an intraoperative ultrasound to score the tumor, and then we'll start resection of the tumor.
So that's a very good point. There are some centers that routinely use intraoperative ultrasound. I only use it when I really need it. I have it available all the time. Every single case, I have it available. But for the real endophytic tumors, for example, I'll show you, I'll use that. Yes, Rajesh?
I think I would say the same, that it's not essential that if you have ultrasound, you have to use it all the time. In exophytic tumors, when you know from the CT that it's demarcated so well by the margin which is going out, you can just mark it.
And use your visual cues to do the rest.
But Rajesh, you agree that if you want to start a robotic renal program, you need one.
Absolutely.
Because you never know what's happening.
Absolutely.
It can be sticky fatty tissue, whatever, that you absolutely need.
Like I said, I always have it available, always. So again, we are doing a deep parenchymal rhinorrhaphy. I use a barb suture. You can use the quill or the V-lock. Both of them have advantages and disadvantages. Here we are using the quill suture for the deeper layer. And then we will use the capsular rhinorrhaphy. See how again the fourth arm here is holding my kidney and stabilizing my the defect right there. I'm using a lapra tie to secure that.
May I ask the other panelists what they use for the inner rhinorrhaphy? So first of all, are you using the double closure technique, inner rhinorrhaphy, external rhinorrhaphy, question number one. Number two, what type of suture are you using?
We use we suture it in 2 layers. One layer is with V-lock. The second layer is a sliding rhinography technique in which we use a CT1 needle. Initially, we used to use the bolsters, but we had got few cases of bolstromas and the CT picture post-operative was quite confusing. So we have stopped using bolsters. So once the second layer is done, we use a Surgiflow.
Yeah, I just want to show this vein here. This is the main renal vein. Actually, why don't Rajesh, you finish and then I'll show you.
Yeah, I use 2 layer, but my first layer is not that through and through layer. I just do pinpoint. I'll close the pelvic ileal system and the obvious vessels which are seen on that. And I'll do that with the 4O PDS and then use just the sliding rhinography.
That's exactly what I do. So.
I do real 2 layers, and in my first layer I use a monofilament and usually monocryl, and it's loaded with a clip. I go outside in with it, and I really go with the running suture through the full defect. I want to do this before with a monofilament and not with a barred suture. Why? Because I want to keep the defect open, and I first make my mattress. And at the end, I go inside out with it, put again a clip, take eventually a second one. I have not put any tension on it. And only once I've done it completely, because for me it's important that you keep the defect open, because all the retracted vessels, calyces and whatever, they all go in the same suture. It's only when you have a very deep defect that I would do a separate one. I believe it's going quite quickly. And usually this is so well done that we can easily, once we've done it, we get the clip, the bulldog off, and we do early unclamping.
Yeah. So here I want you to focus on this little step. See this? This is the main renal vein. See this right here? Right here, this is the main, see this? This is the main renal vein. So you have to be very careful when you're closing your defect. You take 1 millimeter away or deeper, you can go through the renal vein, to the main renal vein. So you have to be very cognizant of these points when you're doing your rhinography.
What suture is this?
This is a quill stitch, Alex.
Also quill?
Yeah, this is a quill.
This is all quill?
This is all quill,
okay,
yeah.
good.
So you can use the quill or the V-lock. They are the 2 main barb sutures. I like the handling properties of the quill, but the holding properties of V-lock are significantly better. But the V-lock sticks to the tissue, it snaps off, so on and so forth. So I just use the quill. And it's cheaper. The quill is cheaper compared to V-lock. What's the length of the quill? I think this is typically, you can have a 6-inch or a 9-inch. So for big defects like this is a 9-inch. So again, we remove the venous clamp first, and then we remove the arterial clamp. And here, I'll just remove it. I won't remove it completely. This is what I do. I just kind of unclamp, check for any obvious bleeder, and once there's no obvious bleeder, then I remove it.
Here you clamped the vein. Is that routine?
This is a very large tumor. It was very close to the hilum and the vein, and that's why I clamped the vein. And again, I don't use any bolsters, no Surgicel, no fibrin glue or Eviseal or Flow Seal or anything like that. Nothing, and this is done.
Okay. Some questions or remarks in the audience, please.
Do you have any experience with other energy sources like PK or harmonic cutting the tumor?
Yeah, so basically, let's go off the panel if I may. So basically, I only use monopolar. So I don't have a bipolar because we are quite poor in Europe. So basically, although I use 4 arms, I use 1 scissors, 1 pro grasp because it grasps better than a bipolar, even a fenestrated bipolar, and 1 needle holder. So I do everything with that. So having said this, I use the suction irrigator more and more often, but I don't use other energies for this indication.
I think that's a great point which Alex made, that the economy of instruments, you have to, during evolution, you need to learn how to use less and less instruments. But that's a great point, that if you think that bipolar is more of a overuse in kidney surgery, it's essential part probably in pelvic surgery. So one can do with monopolar, but we use both monopolar and bipolar. But for parenchyma cutting, while removing the tumor, no energy is used. it's never, I don't think I have ever used an energy.
I cut it cold, but Rajesh, a lot of people who are in this camp of zero ischemia, early unclamping, so on and so forth,
Yeah,
they
would,
have
they
to
would.
excessively rely on
Yeah.
actually.
But it makes parenchyma
electroenergy.
so black.
Absolutely,
That,
it chars it.
The
You don't have
basic thing when you resect is you want to see the normal kidney all the time. You want to see pelvic ileal system. You want to see the vessels. What you are cutting. You want to see the parenchyma. And once you see everything, you do a better job.
Sometimes when you clamp, still it bleeds. What's the reason for that?
That's a great point. So sometimes when you clamp, if you're both the artery and the vein clamped, and if it's still bleeding, you may want to just take the venous clamp off. But the most common reason, as Rajesh pointed out early on, is a missed artery. Either there's an aberrant vessel or there's a vessel that you know, but you've somehow missed it. And at those times, most of the times, it's too late to then go back and try to hunt for the vessel and so on and so forth. You just have to live with it. That patient will have slightly more blood loss compared to your other patient. And then, you see the vessel, and you obviously, you cannot do it leisurely. You cut the tumor, and then you suture it while it is bleeding. Sometimes, as you are dissecting, you find a blood vessel, and you use the tumor itself to compress the bleeder, ask for a suture, and then bleed it. I personally just keep going, except that there will be slightly more blood loss, and I'll just do it the same way.
I think that's a very important point. That if you have bleeding during dissection, during initial part of the cutting, there would always be bleeding because the kidney has blood. Don't worry about that. But if it's bellowing out of the bed between them, then one of the things is that it take the vein clamp off, and it's usually an aberrant artery. If it is going to the upper pole away from this, then it's a back bleed from the vein, and usually it will stop if you just take the vein clamp off.
So just in the interest of time, I'm just going to show you a few more interesting videos. This is a right-sided hilar dissection. This is the cava. You can see, I'm just going to expedite the speed of the video. This is the cava. Again, going on the right side, there always is small blood vessels, lymphatics. Then you can easily use your bipolar energy source. So blunt dissection, you can see the renal vein here. All this lymphatics will go away. You're dissecting it right there. There's a small little bleeder right there. They just took a bipolar and buzzed it. Again, look at the kidney. It's completely lifted by my left arm, by the fourth arm. It's completely giving me traction and keeping the artery and the vein at great stretch. So this is the artery. You can see the artery is right here. And there are two branches. There's an anterior branch and a posterior branch. This is the vein, the adventitia of the vein. I'm going to go all the way up. So the vein is now circled. There's one more vessel. You can see it right there. But I have enough to put a clamp on my vein. And you can now see the other artery. See, there's one more artery. There's a... taking all the lymphatics. And now you can see the anterior branch and the posterior branch right there. So you can do that. And now I'm going to go to a couple of challenging cases just in the interest of time. This is a patient I just recently did actually about a month back. A morbidly obese patient after bariatric surgery was still weighing 380 pounds. This is the tumor, a large tumor. No, not this one, sorry. Yeah, this one. And see how I videotape every single case of mine, whether it's a prostate, a bladder, or a kidney, and I'll show you why, when it can help. It doesn't help in most of the cases, but this is the tumor right there. This is a morbidly obese patient. This is the tumor. See all this right here, lower pole? This is the ureter. I'm doing the surgery. I'm trying to delineate the tumor. It's a very challenging case, male patient. After a bypass, lot of fat, lot of adhesions, is bleeding everywhere at the capsule. But I want you to focus on how your assistant can, one small error can lead to what problems. So again, I'm trying to mobilize the tumor in a very gentle fashion. And I'm going to expedite this. This is the tumor. And this is the ureter here. And see this now. You see what happened? See this? See what happened to the ureter? Yeah, no, it cut. See this. with the traction of the, see this now, see this, look at the suction, see that? So what do you do at this point? There's a big guy, you have a large tumor. At this stage, I didn't realize it at this stage, by the way. I realized it maybe 5 minutes later on, and I thought that I did something wrong, quite honestly. But it doesn't matter who did something wrong, but this happened. So what did the panel do next?
Well, I first also do like you and blame the assistants. And
I did not. I did not blame this. Like I said, when I did it, I thought it was me who did this.
yeah, I'm joking. But if this is not an imperative indication to keep the kidney, I would probably take it out, but
Okay.
to avoid complications.
Rajesh, what do you do?
I think one of the things is that I always ureteric catheterize all my partial patients. So if that is the situation, then probably, you know, it may not have happened or could have been avoided.
Okay.
But yes, you know, if it's an absolute indication for a partial nephrectomy, then definitely, you know, you would do it like you would do a repair over a stent.
Arvind, would you do anything different?
We also place an ureteric catheter, and I also agree with the other panelists.
Yeah. So what we did was that we still, obviously, as Alex pointed out, it was a thought in my mind. It was a pretty large tumor to begin with, a very challenging anatomy, a morbidly obese guy. And I thought that, look, if I have to do a radical nephrectomy, it's still a good operation for this guy. But what I did was, I didn't want to make a judgment about that solely on the ureteral injury. I wanted to see how the tumor went. And remember, radical nephrectomy is just one step after partial nephrectomy. So if you've done a partial nephrectomy, and so many times you find a thrombus in a vein or some other aggressive feature that prompts you to do a radical nephrectomy, all you do is use a stapler and do a radical nephrectomy. So what we did was, we gave it a shot.
Dipen, one remark. Why would you do a radical nephrectomy in a guy where you see a renal vein thrombus? I believe there is no literature that shows us that doing a radical nephrectomy when you encounter an intrarenal vein thrombus. So for that purpose, we will ask everybody, and if you have cases, it would be great to bring them all together.
Absolutely, in the database.
To see whether a partial, where you did have free margins, of course, where you have these renal vein thrombosis, if they are doing better or worse. I think there is no philosophy why taking out all this parenchyma would be better for the outcome.
So Alex, I'm not talking about a small venule with a thrombus or something, but if it's really going into the main renal vein or something like that, that's what I meant. But anyway, so this is what we did. We removed the tumor. We didn't do anything to the ureteral injury because, you know, I just wanted to first remove the tumor. We removed this tumor completely. There was no problems in getting the tumor out. And then assessed the defect. I put a intraoperative urethral catheter. Obviously, at this point, by the way, the tumor defect is showed, the kidney is unclamped, all those things. The tumor is right here. See the tumor? The tumor is already excised. It's all done. So without any pressure now of the kidney being clamped or anything, my surgery is done. I just have to fix the urethral defect. So I just closed it in a single layer over a double J stent and called it a victory. The patient did well. We removed the stent in 8 weeks. His kidney is functioning beautifully. But just something, and by the way, at the time, till after 2 or 3 weeks after the surgery, I thought this was something that I did. In fact, to his great credit, my fellow, Sanjay Swain, he looked at the video to see exactly, and he pointed out that it was a suction injury. So I didn't even know, but this is the advantage of recording your case.
Yeah.
It gives you...
So Dipen, I think I am like you and I never stent my ureters. So perhaps this is a lesson to do because I was a little bit surprised to hear that 2 of the panelists routinely catheterize their ureters. Or am I wrong when I say this?
You are right. I always catheterize my patients, ureteric catheterize my patients.
In our first 20 to 30 cases, we used to do them in all the cases. But lately, in the past 20-25 cases, we are avoiding placing a catheter in a completely exophytic tumor. If it is near the pelvic LHS system or medial tumor, we place it. Okay.
So
to be honest, I never stent because I have in 400 cases or so only one urethral urine leak, and so.
So, you know,
We don't leave the ureteric catheter later on. Yeah,
Right,
yeah,
right.
just at the end of the procedure, it's taken out.
yeah, I never do it routinely at all. The only case actually where I've done it preoperatively is when I did the live surgery at UCCon last year at Ames, where this patient had bifid, complete bifid system, and the tumor was between those two bifid places. So I just put it in that particular place, and I was doing live surgery. But otherwise, I don't. do
What I love is that sometimes it helps you, that, when you have the tumor bed, you just ask somebody to flush it, and, you have the flushing of the surface, you see the surface much better. So, I have got used to that flushing and seeing the pelvic calyceal system tears and repairing that immaculately before closing it, because as I said, that I don't do a blind first layer. I do a pelvic calyceal system and vessel repair independently wherever the bleeders are seen. Yes, sir.
I also don't want to routinely any tester for partial nephrectomy. And it was okay when we were doing open or laparoscopy. At that time, we had some limitations, and we understand that. But with the robot in place, when you're doing with the robotic, the vision is so good. What is the advantage that we are gaining by putting a ureteric catheter and flushing?
Perfectly fine. There are different ways. As I said, that
It's an
maybe
individual preference.
I don't see it's a proof of doing something better. What I'm saying is that that's how we have been using it, and we didn't deviate because we didn't find any disadvantage with that.
I think it's an individual preference. If whatever makes you feel
No,
better.
that is okay, but it takes your OT time. You have to place the
No, no,
patient, you have to place a catheter.
Look, I can't fault anyone for being more safe. So while you may not need it, he feels safer doing
But
it.
by
you
the way,
can't-
your patient that did very well, you did in the workshop the time which you referred to, that you did the patient.
Correct.
The patient did very well, there was no post-op problem.
Thank
It's
you,
fine.
appreciate it.
Okay?
Thanks.
The follow-up is good.
Thank you.
So thank you very much, Dipen.
Thanks a lot.